If you're in the Zoom, I hope you are here for the Monogenic Diabetes office hours. This is our program put on by the University of Chicago Monogenic Diabetes Research Team. We've been putting this on about once a month or so for going on a year now, which is crazy to think. But we're glad you're all here with us. If you want to claim or need to claim CME for this session, the info is on screen now. If you're claiming CME through another accredited program, please don't do this and follow the instructions you've been given. Today's panelists include Dr. Lou Phillipson, Dr. Rochelle Naylor, and Dr. Siri Greeley, all on faculty at the University of Chicago and great members of our team. So we're excited to have them all here today. A quick little disclaimer that we're going to avoid talking about PHI or PII during the slides. Please, if you're presenting a case, also try to refrain from doing this auditorily. This just helps allow us to put the recordings online without any risk of PHI getting out. Cool. So our first case today is with Chelsea. Chelsea, I think I saw you somewhere in the list here.
Yeah.
Yeah, there you are.
Can you guys hear me okay?
Yes, I can hear you great.
Great. Well, hello. Thank you for putting this on again. I'm trying to...
Just let me know when you want me to invest the slides.
Oh, okay. Thank you. I don't have any financial relationships or anything to disclose today. So I began seeing a woman when she was about 68 years old at a rural health clinic. She came to me after going to a new primary that she started seeing, and she had type 2 diabetes for a while, recently had lost about 30 pounds, and her blood sugars just were not under very good control despite a very appropriate, good, healthy diet and a lot of exercise. So she just wanted to learn more. When I met her, she told me that her daughter had type 1 diabetes. And so she knew a little bit about carb counting, but she had just never really got much into it for herself. So she wanted to just brush up on things. But in chatting with her, she was doing a wonderful job. So we got into her history a little bit more. And she told me she had blood sugar issues since she was about 32 years old. I believe this was during a pregnancy. She had 4 pregnancies. And babies were born with birth weights of 8 pounds 7, 8 pounds 3, 10 pounds 6, and 8 pounds 6. And this is in the late 70s. She was not aware of gestational diabetes, but suspects that she did have it with at least the 10-pounder. All deliveries were at term or before term. If you go back a slide, she went on to develop prediabetes. Again, despite it, she had a very healthy and active lifestyle throughout her adulthood, and got diagnosed with type 2 diabetes in her early 50s. Her A1C was 8.9. So she did a fair job of managing that. But like I said, by the time she had gotten to me, she's like, well, what am I doing wrong? Because I have these blood sugars in the 300s. And so with her daughter having type 1, I asked her about her parents as well, and her dad had type 1 as well, and had actually died from foot infection and kidney problems. And so I thought, oh boy, I wonder if this is some sort of MODY, and I got excited. But of course, we need the antibodies. And so we sent for those, and she was GAD positive. So her GAD was 2.27, yep, no insulin antibodies. And we did a C-peptide with that, and it was 2. So she still had some insulin that she's making. So we switched her management from metformin to a very low dose of insulin and monitored that. Just did a repeat C-peptide in 2022 so she could get it on an insulin pump because her management was getting much worse, and it was 0.8. So she did get that pump approved. She's currently managing very, very well, but she is a very type A personality and really tries to do everything exactly by the book. So, and despite that, her blood sugars are still pretty touchy. If she does something a little bit different, they go high or low. So I suspect that her C-peptide is probably about 0, just based on our clinical picture at this point. So the questions that I had Oh, sorry. If you could go forward a slide. I think I got everything on this one. And yeah, so yeah, that one. Um, the question I had was that I heard in a previous session you talking about autoimmunity can be genetic as well, or maybe I just want to learn more about that because there is a lot of autoimmunity in her family. This is my attempt at a family tree. She would be the circle on the far left, in the middle. Can you point to that, Emily? Yep, that one. So she had her initial autoimmunities were diagnosed in her 40s. I think that was lichen planus and Hashimoto's. Since then, she's developed type 1 and she has suspected RA. She's getting tested for that, I think, this week or next. And then she has some sort of autoimmune inner ear thing where she can't hear for weeks at a time, and then her hearing comes back. And then she can't hear for weeks at a time, and then it comes back. And it's kind of this cyclical deafness that she gets, which they think is autoimmune. Her dad was diagnosed with type 1 at the age of 32. Like I said, he died about a decade later from diabetes. No diabetes in his grandparents that she's aware of. Her daughter was diagnosed with type 1 at the age of 5, and her son with eosinophilic esophagitis. Her sister has RA and psoriatic arthritis, and her nephew with vitiligo. And then her other sister with RA. So with so much autoimmunity in the family, I guess that's my one question is, can you tell me more about that? Is there anything she should be tested for or the rest of her family tested for? And then the second question I had is that this is just a really interesting picture with her diabetes and such a long, kind of a long progression of her diabetes. And do you think she had type 2 prior to having type 1? Or do you think that there is something else in that picture? Or do you think it's just type 1 and it just had a really long landing pad because of her relatively healthy lifestyle and low carb intake during the years leading up to it?
Yeah, so we sometimes take turns responding, but since this is one of my projects, maybe I'll go first. And let me just say, Chelsea, it just reminds me how awesome you are that you sort of, picked this up and took the family history and did a great pedigree and, pay attention. So it's really, a blessing for your patients to have someone like you around. So absolutely. So, when we hear a story like this, we say, well, is this a non-autoimmune or an autoimmune kind of classification? And what you pulled up is someone who looks like, as you say, maybe a long, slow path to autoimmune diabetes in a compelling family history. We are, in fact, doing research in this area, but before I get there, I'll just say a few other things that and there's a note in the chat that, yeah, I would say a lot of autoimmune disorders, and maybe all are genetic in some way. What's different is when there's multiple generations and multiple kinds of autoimmunity in one family or even in one person. So we have published now a few papers with the group that I'll talk about at UCSF when either one person or multiple generations have multiple kinds of diabetes. We know in the absence of diabetes, there are genes like AIRE, AIRE, that control many different kinds of autoimmune things. Our friends in the UK, Dr. Hattersey's group at Exeter, has said that if you have sort of the usual triad, which would be type 1 diabetes, hypothyroidism, and celiac disease, that's not necessarily that interesting from a scientific genetic point of view because those happen together with some frequency. We know that something like 9% of everybody with type 1 has celiac, and then probably for hypothyroidism, it's at least that high. The other way around, I'm not sure we know. In other words, how many people who have celiac have type 1? So that's something that people at like the Barbara Davis Center have more folks, and so they're looking at that. So here we have this family where this woman had obesity and then, or at least type 2 diabetes. I don't know if was she ever really obese, Chelsea?
No, no, I don't think so. I think she's always been like between normal and overweight, kind of at the 25, 26 mark.
Yeah,
She's
which I would say is
very
perfect.
active, loves exercise, eats healthy all of her life, as far as I can tell.
Yeah. So I think, and then there's obviously there's implications for the children. So and definitely, maybe I'll have Ro talk about that in another minute. So so basically, so she has like at least 4 things, and then multiple other family members. So the study that we're doing is with a group at University of California, San Francisco. So Mark Anderson, Mike German, Chester Chamberlain, and a few other people. And so we're kind of one of the front ends of that study. So we're collecting folks through our registry, and we have it, and Lisa just put it in the chat. So it's called the Precision Type 1 part of our overall registry. And so it's the same people can go to that site, they can join up. We will take their history, we will get DNA and do the kind of history that you've already gotten for us and make sure with informed consent we can put that in our database. And we will often get DNA from other family members. So one of the children, maybe a sibling, who can also help us to be sure that if there is a genetic linkage, that it makes sense. Many times people have various sorts of gene rearrangements or point mutations or changes, and they're not the cause of the disease. So that requires oftentimes looking at multiple family members, and this is a perfect family to do that. So we would do that. So I'll add, so that's the study. And so it involves sequencing, in this case, whole exome sequencing. So instead of going for candidate genes, we basically sequence all of them, so 22,000 genes for that study. And we then sort through that and see whether there are candidates that are known to regulate the immune system. And then otherwise, we might save it and then see whether there's something else that comes up where there is a mutation in a gene we might not think of that could explain this with the other family members. So in the adults, I'll leave myself to that for a moment. Are there other things to check for? And the answer is absolutely. So certainly, if this was my patient, I would be checking her at least every year for some other things. Now, she already has Hashimoto, so she's already has hypothyroidism. I presume she's on thyroid replacement. So while some of these things are exceedingly rare, they may not be so rare in this case. And so in children, we would be looking for adrenal things. So doing auto antibodies for adrenal disease would be one thing, but then the general screening tests can be very helpful. I get a CBC on such folks all the time because of the possibility of pernicious anemia. Sometimes looking for B12 alone is very helpful because you can see a B12 sort of low-ish. I don't like B12 to be really even close to the bottom of the normal range. I've seen people who have neurological symptoms with early pernicious anemia before they have even any change in the CBC or show anemia. So they have neurological symptoms before that. And one could imagine other things, like a careful exam. You have to sort of keep your keep a wide net. And I'll just mention, recently I've been delving into this a little bit more, and so there are people who think that some neuropathies can be autoimmune. Certainly, we see that in cancer. So that if there are neuropathies, it may not. It's given how well controlled she's been, that if she does have certain other things, I wouldn't say, oh, that's just because of this or that kind of diabetes-related neuropathy. It may be that there's an autoimmunity involved, and same with kidney disease. So she could have autoimmune kidney disease and not diabetes-related kidney disease. I was just talking about this to one of our experts, Dr. Bacris, and saying that I often send people now to nephrology thinking that they might do a biopsy, and they never do a biopsy. They always assume that it's diabetes-related kidney disease. But it could be something else. And so then you have to push a little bit to to have the nephrologist really try to make a diagnosis and have diabetic neuropathy, if that's so what we call it, diabetes-related neuropathy, to be a diagnosis of exclusion. And I could probably say a few more things, but let me stop there. And because there's a lot to say about the children and what screening should be done there.
I'm good. I'm following along.
Yeah, I was gonna say I won't necessarily stay in my lane, so to speak, and talk only about the children.
No, and I don't want you to.
Yeah, well, I think it's in part because it's not completely clear what screening to do in the children. What I will say, obviously the studies of autoimmune related diabetes are really necessary, because I think it's still debated whether a lot of people would refer to this as LADA, latent autoimmune diabetes of adulthood. And there's a debate whether that's actually a distinct thing, or is that just, like you said, type 1 diabetes with that long landing strip. And I think there have been some studies that would suggest that, at least if you're looking, if you kind of cut people by age group, that there are some genetic differences in what we would all agree is type 1 diabetes versus what some may label as LADA. And it makes me, and I don't think I'm alone, I think the general medical community, it's a little unclear to me whether or not we need to, whether or not we should expect that the children are at risk for sort of our rapid onset, rapidly progressing type 1 diabetes in a family that otherwise seems like it has this later onset, slow burn diabetes. I don't know the answer to that, and I don't think the answer to that is yet known. So certainly, what we can hang our hats on is the appearance of antibodies, signaling risk. So I think children should all be screened for antibodies against the beta cell that would suggest their risk for type 1 diabetes, whether it's going to be the sort of rapid classic onset or, again, this later form. What else to look for beyond that is also questionable, because clearly there's lots of autoimmunity, more under the hat of rheumatology in terms of increased risk, and I will definitely leave it to a rheumatologist to discuss whether or not they go around screening, because we know that sort of the markers of rheumatologic autoimmunity are not as prognostic. Their presence is not as prognostic. I think that these cases, very carefully elucidated, just really highlight the need for studies. And I agree with Lou that referring this family, if they're interested, to these studies will continue to help kind of elucidate what's going on. But yeah, I think in terms of the children, certainly I think everybody needs screening for the antibodies. What else needs to occur is a little less clear, because again, it's not whether or not this is a distinct process with some different risks from our classic type 1 diabetes has not been settled.
Yeah, so that's a lot. So do you know about the children, the nieces and nephews, Chelsea?
Just that they're young adults, and I bet they have children of their own. I know that they have, because I know she's a grandma, and I didn't get that information in, but I don't think there's anything there yet to put in. So,
well, it could be very interesting. I mean, if we were to find, some control mechanism that explained it, I mean, publishing the entire, I mean, it's I think it's a publishable case about how illustrative it is. Illustrative it is. So that could be good. And to take a moment, I mean, we could do it. So if they do enroll in the study, as Rose said, if they're interested, we would try to carefully get the family history down to the, third generation or later.
I'm pretty sure she would be interested. She's a pretty scientific, I want to do everything I can for myself and my family sort of gal. So I will definitely let her know about that.
Yeah, I think that, is there an advantage, right? So it may be there's no particular advantage in terms of treatment, but there could be an advantage in terms of screening. The kids could be in TrialNet for the type 1 thing. Siri, did you want to say?
Yeah, just a couple of thoughts along those lines, just to emphasize for anyone like thinking about whether they have families appropriate for this study. Like the one caution I would say is as you were just mentioning, this is a study kind of really trying to understand genetic underpinnings, and it's pretty unlikely to lead to major differences in treatment. But like you said, anyone who's like motivated and wants to contribute to what's understood and everything, it's really great to have them. The other thing is this family really displays the two main inclusion criteria, which are seeing the diabetes in multiple generations, especially what looks like autoimmune diabetes, where here it looks like we have 3 generations, where at least 2 of them are almost definitely autoimmune, but the later one may have been autoimmune as well. And then having, as Lou said, not just the celiac and thyroid, but other kind of unusual autoimmune associations like rheumatoid arthritis, and eosinophilic esophagitis, if I can say it. So I think a great case for the study. One additional thing I wanted to point out, because Rochelle or Dr. Naylor was talking about screening, is we have a couple of families who are joining this study who have been either have already received teplizumab or are in process of possibly getting it. And even though those families may or may not have the bread and butter usual autoimmune type 1 diabetes, we know it's seems to be autoimmune mediated. And so as far as we know, the teplizumab might still be an appropriate treatment. That's something, this whole idea of precision medicine, all these genetic things may help us to understand who is going to respond better or not to that kind of treatment. But that is one rationale for potentially doing screening of autoantibodies in kids who are not yet affected, which is a thing that we do through TrialNet. So that's actually a great way to get people screened through a research study where they're monitored and everything. So you can refer any family members to join TrialNet. That's the easiest. Although theoretically they could do clinical antibody screening. And if they are positive, they have risk of progression and everything. The nice thing about the data that comes out of TrialNet is they've kind of set up this paradigm where if you screen someone at like 2 years old and 8 years old and 16 or something like that, or maybe it's even twice, then you're pretty likely to catch most people. And if they're already like 15 and you screen them once, your likelihood of progressing later in life is much lower. So it's not like you have to screen them, every year for 20 years. That's kind of. Whereas with thyroid disease, we don't know. And I'm sure all of us have those families in endocrinology where they're worried about thyroid disease. And, we do TSHs like all the time. And everybody, at least it's not that hard to do.
So I think so. The answer to Chelsea is that it's very interesting, and we think that maybe with genetic testing we will be able to provide answers and a heads up for other generations, maybe a treatment one day. But I think this is one of the emerging threads in all of clinical care, is thinking about the genetics of autoimmune disease and how that relates to diabetes. So we will be following up with you.
Thank you so much for your attention and your information about that. It's very interesting.
I will say one last parting thought. I think, to me, this is the reverse of sort of what pediatricians have seen with type 2 diabetes, right? It used to be that children didn't get type 2 diabetes. I also used to be able to say with confidence that anybody who wasn't pubertal didn't have type 2 diabetes, and yet those statements can't be said anymore. And so while it all is called type 2 diabetes, and we know there's a lot of shared risk factors, there still is something inherently different about the condition presenting in a 9-year-old compared to a 59-year-old. And I think it, maybe with type 1 diabetes, we're seeing that sort of same trend in reverse. And of course, in previous decades, the likelihood that all such kind of slow burning cases would have been misdiagnosed as type 2 is very, very high. So I think we're just right at the beginning of being, the kind of the tip of the iceberg of really trying to start disentangling the two main polygenic types that are clearly multiple types, wearing the two different labels.
Yeah, I'll echo the panelists in saying thank you, Chelsea, for preparing such a great case and for presenting it today. We're going to pivot over to our second case today, which is a little bit different, but that's the fun part, is having different cases. So go ahead, whenever you're ready.
Hi, I actually presented last month, so thanks again for letting me present this month. My name is Reem. I'm one of the peds endocrinologists at the University of Utah in Salt Lake City. I have nothing to disclose. So I was hoping to talk about a child that I saw in clinic. This is a 16-year-old female that was referred to us for prediabetes. She had presented to her pediatrician initially due to concerns for fatigue and polys. Fatigue and polys, occasional abdominal pain, wasn't really feeling well. So the pediatrician had done some lab work and was found to have a hemoglobin A1C of 5.9, I believe, on presentation. Just FYI, her BMI is within the normal limits. It's not elevated. So because of the A1C in the prediabetes range, the patient was referred to our clinic for further evaluation. When I saw her in clinic, of course, I did check for the 5 type 1 antibodies, and she was negative for all 5 of them. I also got a baseline C-peptide with a plasma glucose, and you can see that it was detectable at 0.8. The C-peptide was 0.8 with a plasma glucose of 76. I had also rechecked her A1C, and I think it had at one point gone up to maybe 6%, but never in the diabetes range. In terms of family history, when I met with the mom, there was a lot of family history of diabetes and prediabetes. So as much information, the family provided me, or the mom provided me with the information that she knew. So maternal great-grandmother had both apparently type 1 and type 2. Maternal grandmother did have obesity as well as prediabetes. And then there was a maternal aunt who has prediabetes but is not with overweight or obesity. And there's no autoimmune conditions that the mom is aware of. So of course, when I saw the prediabetes, the negative antibodies, I proceeded with MODY testing, and it showed that she had a heterozygous variant in the ABCC8. Which was VUS. I believe it was done through Invitae. Yeah, so familial testing was offered, but it's been hard to get in touch with this family since I met them. And unfortunately, we haven't been able to even see them back in clinic. But when I have been able to talk to the mom, they're not checking glucoses regularly, but occasionally she was having blood sugars, in the hundreds, sometimes above 125. The highest mom ever checked was 140. But again, really hard to really know what's going on at home since there's not much follow-up and difficult to contact the family. And just because of the history of polys, I did evaluate for ADH deficiency, and that was ruled out as well. So I guess my question with everything that I presented in regards to this VUS and the ABCC8 is kind of what do we know about it, if anything? And then how do I educate the family? And is there any utility in, providing medications, whether it was a sulfonylurea or something, to see if it may prevent the progression if she were to develop diabetes?
Lou, did we say I was going to take this one? Okay. So, yeah, thanks for presenting this case. It's a great example of a few different things, among which is just how do you deal with the VUS. And as you can see, we added in the some of the other information we were able to find about this variant. This comes from Bala, our research fellow who is on vacation right now. But from his review of the data, it really looks like this variant is actually benign. And the amino acid is, first of all, only moderately conserved, which means that in how many different species is that particular amino acid the same at that homologous position or not. The biochemically speaking, for those of you who remember from biochemistry, like how much the amino acid has changed, the isoleucine, the valine. Lou, I think we were discussing a different variant with the same change earlier today in a different case, and Lou was noting that that really isn't a very big difference. And furthermore, they have all these prediction tools about how damaging it might be to have that change in the amino acid, and those all had a pretty low score. And then one of the big things is the allele frequency, which that might look like a really, really low allele frequency, but even having a few heterozygotes in the NOMAD database does tend to argue against. So we think of like a 0.001, that's kind of like on the threshold, like theoretically it might, but it tends to argue against. In many of the rare variant cases, what you'll have is that it's just not present at all in NOMAD, or there might be like one person or two. So all of those things seem to argue pretty strongly against, and really the phenotype doesn't really fit with a typical phenotype for ABCC8 unless it was progressive. And so if the diabetes, because as you mentioned, the person doesn't really have a diagnosis of diabetes yet, but if it was progressive, then we'd be having a different story. So I think going into it, first of all, with the idea that this variant does look benign, the things you can do is you could offer testing in the family, which can be helpful if the mother, for example, I think you said was unaffected and has not had any high blood sugars. I don't remember about the father if you mentioned it, but if either the mother or the father carry the variant and have gotten to their age and continue to be, unaffected by diabetes or high blood sugars, that helps to further argue that this is not a highly penetrant cause of monogenic diabetes. And when you mentioned about glyburide, I know when we see these kind of variants, the clinician in us and our desire to want to treat, like you get this sense like, well, maybe, a sulfonylurea would help or whatever. I think we really have to kind of caution against that kind of well-meaning intention for a few reasons here. I mean, obviously, in this case, number one is that they don't even have diabetes yet. Number two is that sulfonylureas, other than our special cases where there's a very good rationale for treating, I think sulfonylureas in general have fallen out of favor as a treatment for diabetes for probably good reasons, because they tend to, in people, for example, with type 2, are driving insulin secretion at the expense of beta cell health, I would say, and tend to drive more insulin production rather than trying the other approaches that are kind of reducing your need for insulin, which is a healthier way to kind of think about it long term. So it's a very long-winded way of saying I would definitely not go with sulfonylureas. And in fact, you have to be careful about what you will even report to the family. I mean, in this case, you have a clinical report. You've probably already, if you've seen them, mention the variant, but a family will also get really excited when they hear, oh, there's this variant, maybe it means something, and I think you have to go into it with a kind of a strong sense of like, no, it almost definitely doesn't mean anything. And some labs actually, like if this lab had done a little bit more due diligence, they might have actually not reported it because they might have scored it themselves as a benign or likely benign. And then usually they just won't even report it because they would say it's not related to the person's diabetes, and then you avoid all that kind of confusion. So those are thoughts about the variant. Oh, just one more quick thing is just to say that ABCC8 variants, because some people might be thinking, don't those only cause neonatal diabetes? Well, yes, they're a major cause of diabetes that presents in babies, usually under 6 months. But there are variants that are a little bit less strongly activating, that might have a brief period of hyperglycemia in the neonatal phase that may or may not be detected. So some individuals in a family will have a transient neonatal picture, and other members of the family, you won't have that neonatal history, but they will develop a diabetes that looks a lot like MODY and can present in adolescence or young adulthood. So actually, in that case, in that sense, diagnosis at 16 years old could fit with the phenotype. So I may take back a little bit of what I said. But again, you would still expect it to be progressive. Now, you might ask what to do about this case, like if it's not the ABCC8, and I'd be interested to hear other people's thoughts, like Rochelle. I know we see these cases periodically where you get this A1C that's in a clearly not normal range, and the patient doesn't look like your typical prediabetes patient. So they presumably, you mentioned their BMI is completely normal. They probably don't have acanthosis, and they're just not looking like the type 2 kind of prediabetes. And so the main thing to rule out in these cases you have actually done, which is really GCK, like in terms of our monogenic diabetes office hours. That's the thing you should be thinking about the most here. And your genetic testing ruled it out. However, I would point out that you have that fasting plasma glucose of 76 also helps to rule out a GCK phenotype, because they really have a very consistently mildly elevated fasting blood sugar. So just by doing a fasting blood sugar, you can usually really change your threshold of suspicion or lack of suspicion for GCK. What I will do with these cases sometimes is consider doing a continuous glucose monitor if you really want to get a sense of the patterns of the hyperglycemia. But here, I'm not seeing a lot. I guess the one like clinical consideration for the polyuria polydipsia, I'm guessing it hasn't progressed and gotten worse, given that you're having a hard time even getting a hold of them.
Right.
Like you would hope that if they were getting sick or have more symptomatic, that they would be reaching out to you. But that truly, though, that is one of the most important things you can do with this kind of patient, though, is counsel them on the polyuria polydipsia and whether it is, worsens and continues to be a thing over time. I mean, we all know who've dealt with these kind of cases that polyuria polydipsia, it sounds very objective, but it's really a very subjective thing. It can kind of come and go, like was it during like the summer when they were running around and they were a little more thirsty, and how much are people like paying attention, not paying attention. So, but if it, one of the things I like to use is waking up in the middle of the night to go to the bathroom, or not waking up and having an accident in someone who was previously, potty trained. That kind of thing can actually really, really help a lot. But I think counseling them on it so that you can feel better, that it's not like you're just ignoring this, but you're kind of, if it stays as it is and doesn't change at all, it really should be pretty benign. But the question is it going to progress down the road? And then you want to avoid having them end up in DKA and getting sick and, that kind of thing.
Right.
I've been speaking a lot, so let me give some other people a chance to chime in.
I mean, first off, the case made me remember. So back in 20-ish, I right when I was really beginning my journey into monogenic diabetes, I remember that there was the case report. I think it was a family with a GCK-like phenotype, but the blood sugars were a little too good to be GCK, and then it was attributed to a mutation in ABCC8. I'm going to have to dig it out and figure out if that mutation has or that variant has stood up over time is actually, you know, being the cause of this family's clinical picture. But I do always still feel like, is that a thing, this, you know, mild phenotype kind of GCK mimicker from ABCC8? But that's a little bit of an aside. You know, in this case, we know that the variant is not causative. I do get a fair number of children like this, you know, just I think because, you know, obviously my interest in atypical diabetes or head scratchers, and very similar to Dr. Greeley. I will usually, I'm plus or minus on the CGMs. I will say, depending on my level of suspicion, they are, you know, I'm often having to like say, no, really, that was the warm up period. Please, they're not hypoglycemic. Let's not, you know, chase a new problem down. So it kind of depends on how worried they are and how much they will kind of, you know, just what you anticipate their acceptance of kind of some of the limitations of CGM will be, because sometimes I think we paint ourselves into a little bit of a corner. But what my approach has usually been in these cases is I say, let's get an A1C 3 months after our last one. Then we'll get to, you know, 6 months apart. And then after that, if you can't, you know, kind of live without seeing the A1C in the absence of any progression, in the absence of symptoms, then do it annually, and that can be your regular, you know, like your general provider. But like Dr. Greeley said, I always tell them time will declare itself. Either this will be so stable that we'll all become less concerned about it, and we'll remember it, and we'll try to do all the healthy lifestyle things and attribute it to maybe some potential increased risk in the future. Or obviously with time, it will become apparent as a problem. And that has worked quite well so far. You know, like I maybe I've just been fortunate with the families that have been referred, but they've been very accepting of that kind of plan, find some comfort in it, and just that reassurance, like it will either clearly declare itself or it won't. I have seen with one of these cases that as the child got older, then all of a sudden it seems like this problem resolved. And so I do wonder if this is a little bit of the, you know, numerous genetics that play into everybody's overall glycemia, and whether that plus, you know, the insulin resistance of puberty is enough to just pop these kids into a high, like a kind of IGT range for their hemoglobin A1C that then seems to resolve itself. I only have the N of 1 right now, where I'm like, that's my theory. And so we'll see if it, you know, as a couple of these other patients age, you know, get a little bit older, if that seems to be a thing. But I do think you've ruled out, you know, the things that would progress rapidly, the things that we can't miss. I think that's been done. And so, you know, probably just an approach of a couple of check-ins and you know, obviously like Dr. Greeley said, a lot of counseling of all of the reasons to call immediately versus the ones to follow up with a couple of A1Cs.
Yeah.
Just a couple points in the chat. So maybe, Robin Hayes noticed that in the family history, if you could go back one, Emily, that the maternal great grandmother thought 1 and 2, and Robin said, "Gee, great grandmother, did we really know if it was type 1?" I'm betting that we actually don't know that, and they were on insulin, so they were called type 1. What do you think?
I will admit it was hard. Like, this is as much information as I can get. And again, it was generations ago, so I wouldn't be able to explain how it was type 1 and type 2. I definitely agree with you. Maybe the insulin requirement is what made us think type 1 and type 2 body habit. I'm not too sure, honestly. It's hard for me to give more information. I'm sorry.
Yeah, well, that's what I thought. So Robin asked a good question. I mean, often you see histories go back a long time, and and in fact, you need, for the research purposes, you need to put your skeptical hat on and say, what was it? The only thing I can add is that this case, as Siri mentioned, that we had another similar case we're talking about with ABCC8 with exactly a mutation that changed an isoleucine to a valine, also benign. And some of the things to think about I don't know if you want to zoom out or not in the couple minutes, is, all of this is the KATP channel, and we're very interested in, over the last, I don't know, for me, over 30 years about how that channel works. And so there are two genes, KCNJ11 and ABCC8. In this case, it's what they call a heterooctamer. So there's multiple copies of each gene. And because of that, there's a certain amount of slop in the system that's tolerated, so that you can have mutations that are not very active. And it's interesting to think about the differences in sizes of the genes and the proteins. So KCNJ11 is a relatively small gene, and in fact without an intron, so straight up one sequence and no intervening regions. And a lot of the mutations will cause, if it does anything at all, you can get both hyperinsulinemia and hypoglycemia and diabetes. And then as history tells us, and in fact, the poster right behind Siri there, it's dramatic when you can make a case of KCNJ11 diabetes and treat with sulfonylureas. ABCC8 is a huge protein also with multiple membrane spanning domains. So it with many introns, and I forget if there were 30, I used to know all that. So those are genes that can tolerate, I think, a lot of mutations. And because there are so many subunits in the final product, I think it tends to be less of a dominant disease. So we're still collecting ABCC8 variants, and the family we were just talking about today, the child has something that looks like diabetes, and we tested the whole family. And in this case, mom, who's worried about her diabetes, in fact, doesn't have the variant, and dad does, and his blood sugar has always been normal. So it just tells us that, yes, there's a variant, and no, it doesn't have any particular meaning for diabetes. So there's lots of interesting stuff we're still trying to sort through. And Tony's, who's on the call, Tony Poland, has been spectacular in helping to sort all this out. So, but Tony, I don't think there's been a panel for ABCC8, right? There are just too many. Wait, you're muted. So
usual problem. No, we need to get to it. I think part of why we haven't got to it is the same reason we need to get to it, which is that it's a complicated gene. It's confusing. People sometimes, I think the worst thing that happens with this is when you do have like an infant that was diagnosed and they get back that there's not just a VUS, but a likely pathogenic variant. But it turns out it's a likely pathogenic for recessive hyperinsulinism. And so I think that we need to get moving on that, and I think we need to like promote better reporting of it so that people are getting reports specifically about the variant and related to the indication that it was made for.
I see there's one more question from Chelsea. I don't know if would you want to take it, Ro?
Yeah, I was gonna just mention two things. One, regarding the family history of type 1 and type 2, I will say it's a very common thing to hear, particularly with older people, to say like, and then it turned into type 1. So I think there is this, this idea if someone ends up on insulin that their diabetes turned into type 1. So my guess is that I hear it a lot, and about 50% of the time, do I bother to even dive in? I'm just like, okay. What I was going to say about the GCK. So, as Chelsea mentioned, you really would expect that people with GCK Modi should not have symptoms just based on where their blood sugars are, and yet probably it's a coin toss. So that's just, I think, again, highlighting how subjective that polyuria and polydipsia can be. Again, I think important to rule out, obviously other reasons for having that issue. But like similar to Dr. Greeley, I'm always like, is someone getting up multiple times a night as probably the true test of someone who truly has, and sometimes that still has fallen apart for me, but at least a little bit better than just the parental report. But yeah, generally speaking, we would think that GCK Modi doesn't have any symptoms, and yet a lot of times people report them. So I don't know what that means. I also know people who don't have diabetes at all and still report a lot of symptoms related to, what they perceive to be their blood sugar. So I think it's all interesting, but hard to fully, untangle.
So if I
Could I
sorry,
ask a question? Would I be able to ask a question?
Mhm.
Clinically, before we had all this knowledge that you are spouting, you're amazing. Someone like myself might suggest that diabetes has been considered a wear and tear disease. And when people don't know what that means, we talk about the behavior of not knowing how your body rescues you with what the glucagon can do. And we talk about how you didn't know this was happening, so you sort of abused it. And maybe over time you wore your insulin regulation down and you wore your glucagon regulation down. And we suggest, this is what we've always suggested, right? That it's wear and tear, and that you might be transitioning. Likewise, we often might suggest that if someone was not eating very well over time and they were constantly wearing down that issue, that they may have been bottoming out and having a low blood sugar, that could suggest that they may be more prone to developing type 1 because they were constantly running low. And this is just, I know this suggests a level of ignorance, but this is some of the language that was used when we didn't know all of this. And I was just curious, now that we know so much more, were we close in the language that we were using? Do we know if some of that might have been more true as we talk about diabetes as a wear and tear disease? I'll take it offline. Thank you.
I guess I can take a stab at that one. It's kind of a really big picture concept kind of question, and it's interesting to think about. But I think the wear and tear part concept, I would say, still very, very much applies for the pathogenesis of type 2 diabetes. And I would say the more we learn about type 2, the more it does argue for that kind of concept. Like the cells are clearly capable of making insulin pretty well, but it's only when they're faced with an increased demand again and again and again and again over time, over years, that really they can't keep up. And so I think that concept still very much fits there. I'm not sure there's a lot of data about that for type 1. With type 1, there is in the previous case, we kind of touched upon the idea of LADA, or the slowly progressive, and we're not really sure why some people progress more slowly than others, but kind of the data would indicate that the autoimmune destruction doesn't necessarily depend on the wear and tear kind of components that you're talking about. But I think where it's kind of interesting to think about is that with many of these monogenic causes, we have some uncertainty still on the age at which people are diagnosed. So within families, you might have someone who's diagnosed at 32 and then someone else who's diagnosed at 12. And like, why is there that big difference in the age of diagnosis is still not very well understood. So it's possible that the wear and tear concept might come in there a little bit. Although I think the other issue is just ascertainment. So like whether people are checking or not is a big part of it. So I hope that helps to address that interesting question.
It does. Thank you. And the idea of wear and tear, we've actually had clients that have had symptoms long before they're diagnosed with diabetes, which suggests that, I mean, in our area, we've suggested that you can have had it or been working on it, so to speak, for 10 to 12 years before you know it. And I don't, again, know if that's more anecdotal or if that's, really founded in science, but it would appear as if people have been working on it for a while. And they they develop some of the symptoms that are more of what we would call long-term complications that are, oh yeah, you've got diabetic retinopathy, or, like they're finally diagnosed by their optometrist or ophthalmologist. And, it's like, so I was just curious if we figured more of that out, but thank you.
Yeah, I think we're still learning, and I think it argues for screening people and, when they have pre-diabetes, watching out for progression, that kind of thing. Oh, and the last
to make sure that Dr. Shahar gets her question in for her case.
Oh,
so,
right.
Because we're at 2 minutes. So I'm sorry. I'm just going to cut in because I know that you wanted to add something. So.
I guess I was just curious because I always like to explain, you know, why we have an abnormal lab. Why is it abnormal? And I know sometimes with puberty, you can have insulin resistance. And I, like you guys already mentioned, it's always nice to have an answer, and maybe family, you know, is going to think, wow, this is the cause, even if my doctor says no. But I'm just curious, is there any chance that this variant in the future does become, you know, no? Okay, so it's benign, done, the structure is still working. Okay. Okay.
What you can, yeah, I would tell them like this is not the cause. It was a gene panel. It probably didn't have every gene on it. It certainly doesn't have the genes that we don't know about yet. So I think you can all, you know, it's always very reasonable to say, based on what we know right now, I always say the royal we, you know, the medical and research community, we didn't find a genetic cause. We're going to continue to watch. We may go back and retest, because if things progress or, you know, are persistent in the future, they're new things, we might get new leads. But for now, we don't have a genetic answer. You know, at this level, we can kind of extrapolate from the GCK data to think that this is not going to cause big problems, and we're going to monitor to make sure this is about where things stay. But yeah, this variant, no.
And this was done at Invitae. We don't have the sample, right? Or do we?
No, I didn't send it through you guys.
Just to back up what Ro was saying too. So if there's progression, if you see the family again, you could send, and if they want to know more, they could enroll in our study or one of the other, you know, Tony, there's many studies now where we're doing way more than so the Invitae panel, I think, is now up to 30 genes. And part of our research panel is 200 genes. And then if it's compelling and the child progresses or has something else, you know, then we could do all of them. So we can also do whole exome. And then again, there's also the Radiant study where we do whole genome. So stay in touch for sure. And there's, I think, more and more groups that are interested and able to do that testing. But I think that's the top of the hour. And Emily, do you want to talk us out?
Yeah, thank you all for being here. And if you have to go, please feel free to sign off. I just wanted to put up here really quickly that we are going to take a brief summer hiatus from office hours, travel, conferences, all of that. But we'll return with our third Wednesdays at 2 p.m. on August 21st. So we will see you all then, and we'll certainly send out some email reminders ahead of time. Yeah, if you have a case in the meantime, though, that you'd like to discuss, please always feel free to reach out to our team. This email is the best way to reach us. We won't make you wait till August, but if it's particularly interesting, we might ask you to present. And also there's access to a variety of old sessions online if you are interested in watching those.